Now?
Yes, sir.
Hello?
Now fine. Yes, sir.
Okay.
Yes.
Thank you. I think to begin with, I think it is, again, I would like to welcome everybody who joined us today for this public meeting on keratoconus, understanding the disease and this treatment which are available for various people suffering from various stages of keratoconus. Like to thank all the people who are associated in today's evening program. I think whenever we talk about a disease, it is important us to know what is the actual volume of patients in our country world over, and how do we pick up these patients for a subsequent treatment. So my job is simple but difficult also, to make people understand what is keratoconus. The keratoconus has two words in this. Keratoconus has two things. One is cornea and the other is a conus. That is a cornea getting in a conical shape. So both Latin and Greek words are combined into this. Normally, the cornea is a spherical structure, which is transparent. If you see the below left-hand side picture, spherical, transparent, which is the largest magnitude of a lens which focuses the light to the retina from where we see the image. And once this gets distorted by the disease process like keratoconus, the image can also get distorted because of conical shape. So it is a very slowly progressive disease because of a thinning happening in the cornea and weakening of a cornea. Slowly the shape also changes, and that will distort the vision because there will be induction of refractive error, which will normally we call myopia or short-sightedness. Along with that, there will be a cylindrical power also coming, which we call as astigmatism. And to begin with, this astigmatism or cylindrical power is regular, which is corrected. As the disease progresses, it becomes irregular. Once the surface becomes irregular, the image also gets distorted. So you can understand it's like a lens or mirror. If the mirror is absolutely clean and sharp, the image is very, very sharp. If the mirror gets distorted, then image also gets distorted. And that is what happens in a keratoconus disease. The lens of eye, that is anterior part of the eye, which is cornea, gets distorted because of a disease process with a chronic progressive disease leading to thinning and irregular astigmatism happening. What is the prevalence? How many people are suffering from this disease across the world? If you see this bar diagram, there are different countries that have been demarcated here. You can see the country like India or some of the Asian countries have a higher prevalence of disease compared to other countries where we have a less, like a USA, Denmark, Russia has a lesser magnitude of problem for these patients. So there's a definite change in a profile of a patient in terms of prevalence wise in a various part of the world. In a larger magnitude, I think this is one of the most recent study published, a meta-analysis done, published recently in Cornea Journal, which has nicely depicted, looking into all the studies published in the literature, what is the prevalence of disease across the world. It is around 0.13% if you look into entirety of keratoconus patient in the world. But we see India, you can see the color-wise, the red indicates is more prevalence and the lighter color indicates a less prevalence of disease. India and Middle East countries have a highest prevalence of this disease, which is more than 2.3%. The Western world is very less, 0.04 to 0.05%. But if you see, these are studies which are published through the patient coming to hospitals. So it may not entirely depict the scenario in the masses, in the community as such, because we don't have some sort of a screening study done in a population. But it directly reflects to a patient who require a treatment or who come for a various other procedure and they are picked up by the keratoconus. So this is a good indicator that how many people are suffering from keratoconus. With this diagram, we know that there's a higher prevalence in a country like India or a Middle East. Then you can see China, other parts of the world have a lesser incidence or prevalence in these diseases. In terms of a gender-wise, both females and males have an equal predilection. Sometimes you see more in one particular race, but there's not much of a difference in a sex-wise. It is normally a bilateral disease. Sometimes there may be asymmetry in the two eyes presentation. One eye may have a slightly more advanced disease than other eye. It's very rare to have a unilateral involvement of one of the eyes. The average age of diagnosis or a patient coming to a hospital is around early, we can say late teens or between 20 to 30 years. But in India, it is seen a much younger population than the other parts of the world. So we see younger patients coming to us as compared to worldwide, if you look into age group or presentation of people with this disease. Ethnicity also, as I talked about in the prevalence, India, Pakistan, Bangladesh, there the chances of people suffering a keratoconus is almost 5 to 8 times more than the other countries. The ethnicity also has a significant role in the prevalence of disease. Therefore, we are much more, you can say, if you look into hospital stats or data, we'll see more keratoconus patients than if you are practicing in Russia or USA. There's a definite family history in some group of patients. Various studies will quote around 5 to 20% of cases may have a family history of keratoconus there. Because this is a very, very important understanding for a people. If you have somebody having keratoconus in the family, there are definitely more chances of keratoconus disease coming in their siblings or subsequent generations. So this has impact on our counseling of these people also. So a study which we did in an RP center in way back in 2004 or 5, we saw around 5% of people coming to RP center had a family history. Normally, keratoconus we know is a sporadic disease. It might come up without having any association of a disease happening in these cases. But we know that there are some systemic disease or syndromes where this disease can be associated, like keratoconus, or there can be a local eye disorders which may also predispose or may be associated with this keratoconus. The important disorders or a syndrome which are very commonly seen are a Down syndrome, Turner syndrome, which are the many other systemic features apart from the eye disease happening in these cases. As far as eye disease concerned, allergic disorder, which is very common in the younger age group in India, which we call a vernal keratoconjunctivitis, or some congenital disorder like aniridia, where we have lack of uveal tissue in these patients. Some other associated disorder in the retina also. We all know, people know retinitis pigmentosa, where people have night blindness and slowly they go blind. So sometimes these people can also have keratoconus with associated with these disorders. So how does this happen? What is the basic pathology of keratoconus in people suffering from disease? So basically, if you look into cornea, it has a multiple layers, right? From the outer surface epithelium, you can see here, just below that is a Bowman's layer. Then larger area is a stroma. Then you have a deeper descendant layer in endothelium. So basically, these are 4 or 5 layers which constitutes the entire structure of cornea. In the disease process of keratoconus, there's a thinning happening in the stromal area because of a certain area getting deficient. That is a loss of the cells which are there in stroma, loss of a lamellae, the collagen fibers getting distorted or they lose their strength. And this causes some sort of a response to cause weakening of stromal tissue. And once weakening is there, there's a bulge in happening and conus will happen. And actually, as I said, it will cause a visual disturbance in these patients. So basically, it is a central or a paracentral part of the cornea which is affected most often. And slowly, in advancement of disease, it will involve the entire cornea sometimes also. So it is a multifactorial association of various factors which lead to the keratoconus. So as I said, there may be a genetic factor also. There will be an environmental factor, hormonal changes, and ultimately there are biochemical changes in the corneal tissue to lead into keratoconus as such. Let me briefly take you to the genetics or a genetic involvement in these patients. As I said, there will be a 5 to 20% cases may have a history of family history of a keratoconus. In those cases where you have a family history, the first degree relatives has a almost 15 to 60% higher chances of developing keratoconus in their generation or siblings. Higher in cases where you have marriages happening in the relatives, especially first cousins, which is quite common in the Asian countries. And we have seen that it occurs in the monozygotic twins. Both will have keratoconus. Some sort of genetic disorders, as I talked about, syndromes like Down syndrome, Leber's congenital amaurosis, or allele donors, where keratoconus is very common. And there are various genes which have been picked up in a keratoconus patient, which are associated with disease keratoconus. They would have an impact in not in a diagnosis, but may have an impact on an actual treatment by looking into various genes associated in these cases, especially looking into antioxidant enzyme related genes where anti-inflammatory treatment may be effective in these cases. The future is on a genetic association, looking into which type of genes are affected and their treatment can be directed in those cases. The second important factor, which I talked about, were the environmental factors, which is also very important in a country like ours. We know that eye rubbing is a very common phenomena seen in the keratoconus patients, especially those people who have ocular allergies. So if you have a patient who has a habit of eye rubbing or who is rubbing the eye regularly, there are 60 to 80% higher chance of having this history in a keratoconus patient. So there's a definite correlation between eye rubbing and keratoconus happening in these cases. Ocular allergy also, there are almost 27% higher chances of keratoconus in these cases. Geographical pattern also, hot and dry climates like in Asian and Middle East countries will have higher chances of keratoconus happening. So as I said, eye rubbing will cause mechanical trauma. Eye rubbing will induce release of inflammatory mediators, and the ocular allergy will again, people will be rubbing their eyes. So basically, this environmental factor will lead into a damage to the stroma because of oxidative damage. There will be an increased protein degradation happening in these patients, the loss of stromal collagen fibers, and actually weakening of a cornea happening in these patients. Similarly, contact lens use is also associated with allergy with contact lenses, or a rigid contact lens per se has been implicated as a development of keratoconus, or we are not sure if these patients had a predisposition of keratoconus as such. But yes, any foreign body which causes allergy will have a higher chances of a history of rubbing, inflammation, and development of keratoconus in our patients. So eye rubbing and the allergies will have a higher risk factor for a keratoconus development. What about the actual change happening, which are biochemical factors? So basically, it is two things. One is immunological response and inflammatory response, which leads into keratoconus disease per se. So you have a change in a cell function because of oxidative stress, which we call about, which will actually antioxidant atrophy happening because of decreased antioxidant in these cases, which will be causing eye rubbing. The immune cell activation and secretion of inflammatory cell mediators, which will again act onto the corneal collagen. The raised cytokinins will again affect the biochemical metabolism of these cells. And that will actually alter the cell membrane in these patients and cause protein dearrangement, and collagen fibers will get distorted. So this is a complex phenomena happening because of a genetic predisposition, because of environmental factor, because of allergies, eye rubbing, which ultimately causes biochemical changes, which causes a weakening and subsequent development of keratoconus. The entire process is multifactorial, and it is important to understand this also because that will also lead into a treatment in these cases. Hormonal changes can also be associated. We know that that this disease is suddenly seen in a pubertal area where a lot of hormonal changes happening. If people have a pregnancy, there will be a definite change happening in the cornea. Many people have a progression of disease at that time. Similarly, the raised T4 levels in keratoconus patient can also be associated in that. The hormonal changes also play a part in a keratoconus also. So this was the basic pathogenesis of keratoconus and the prevalence part, which I covered. The other important thing people to understand is who are those people who have at a higher risk of developing keratoconus. Not everybody will develop keratoconus. It is 1 in 2,000, 1 in 5,000 person might have keratoconus. So this is the latest article, again, meta-analysis, where they picked up 6 important association or risk factors where you have a more chances of keratoconus. I think you should understand this. As I said, ocular allergy or eye allergy, where you would have a higher chances, at least 1.5 times higher chances of developing keratoconus than the normal person. Eye rubbing, which may be because of allergy or as such, you have a 3 times higher chances of developing keratoconus. People having asthma, eczema will again have a higher chances. And the more importantly, family history of keratoconus in the family will again be at least 6.5 to 7 times higher chances of developing keratoconus in those population. Then consanguinity, which I talked about. So these are important history which should be taken up in the families, and population wise also. You should know these important things: consanguinity history, family history, keratoconus, any allergy also is an important part. So normally, as I said, it starts at the puberty, that is around between 13 to 20 years. Progresses next 10 to 20 years, which is a progressive stage where the treatment has to be targeted as soon as possible. Or eventually the disease will go, as I said, it's a very slowly progressive disease, would stabilize after a third or fourth decade of life. There's a very rare instances, it would progress much faster in the older population. So how do we diagnose these cases? So there are 3 important aspects of diagnosing disease, which is also important for a keratoconus also. One is the history of patient. They'll come with a definitive history, which might indicate patient may have a keratoconus. Then we'll examine the patient to see if there are any findings which will pinpoint the diagnosis of keratoconus. Then we can do certain investigations which will either prove the diagnosis or it can detect the preclinical features of that disease so that it can be picked up before the physical signs comes up. So there's the importance of investigation have to be done in these cases. The biochemical weakening are picked up by all these investigations, which is very difficult to pick up by clinical examination. So we are looking for those instrumentation equipments where we can detect this disease before the actual symptoms or actual physical signs come in a cornea. So we call it a topography or tomography in these cases. If you see, there are 3 pictures I put it here. One is a simple topography, which scans the anterior part of the cornea only. Then you have a tomography, it's like a CT scan type of picture, where you have a cut section of a cornea can be seen from the anterior to posterior part of the cornea. So it gives the entire detail of the corneal curvature, thickness from the anterior to posterior. Then you have a device which can actually assess the mechanical or back strength of a cornea also. So if you have looking into a sensitivity of these instrumentation equipment, so if you reach up to a device which can give you a tomography as well as the basic strength of cornea, the disease pickup is faster before actually you could see the physical changes happening in these cases. So this is very, very important for a public to understand. Not everybody would require a tomography test to be done. So who are those people where if you come to the hospital, you should ask for a tomography to be done in those cases. So if you come with a history, family history of keratoconus in your family or in your maternal side or paternal side, and if you have a little bit of distortion of vision or you have a repeated change of glasses happening, especially myopic number, then you should ask for a tomography test to be done in those cases. If you're suffering from an allergic eye disease and if you have an eye rubbing as a history, you should always get tomography test to be done. This will give you a chance for a physician to pick up your disease early enough. So as I said, distortion of vision, allergy, family history is an indicator for a tomography. But if you're suffering from keratoconus, you have undergone some treatment, this is the device where we can check for progression or what is happening to your eye with the keratoconus also. We have picked up this disease disorder much earlier than earlier we had, because we didn't have these devices. Thankful to a procedure, laser refractive surgery, where these equipments are compulsory. And the basic idea there is to use the equipment is to pick up the preclinical disease Therefore, we can prevent these people undergoing refractive surgery, because refractive surgery, laser refractive surgery, would also weaken your cornea. And if you already have a risk factors, you might develop the secondary keratoconus. We call it a post-LASIK ectasia in these cases. So these are 4 or 5 points are very important for people to understand. What are the presenting symptoms that people come to us? If you see this diagram on the right-hand side, there's a normal letter which is seen by normal people. This is early keratoconus, distorted, and there's advanced keratoconus. Things are absolutely distorted. So early correction can be done with glasses or contact lenses. Advanced cases require various other things like double vision, nearsightedness, or a repeated change of glasses, especially a requirement of cylindrical power with the change in the axis of cylindrical power is very, very important. And some people come with a difficult night driving, glare, and photophobia also. Complications are quite rare in the keratoconus because it is normally there will be a break in the posterior part of the cornea sometimes, and the fluid can seep into a cornea, which is quite rare. But you will see some patient coming with that also, directly coming with a hydrops or a swelling happening in the cornea. So normally some are picked up by optometrists. When people go for a change of glasses, simply by refraction procedure, they can pick up the keratoconus disease. But these are a stage where already patient has developed keratoconus. These are various clinical features which normally we see for our patients. The hydros, which is not very common for a keratoconus patient, but it is much common in younger patients, especially with a history of eye rubbing and allergies. So it is a very, very important to pick up those high-risk cases and treat these patients as early as possible. There are certain risk factors of hydros or a fluid getting into the cornea with a rupture happening in a deeper part of the cornea. Younger patients, eye rubbing and allergies will have higher chances of happening these patients. Basically, I like to give a brief on our staging so that subsequent people can have easy way to talk about treatment. There are various staging systems based on a keratometric or a curvature of cornea, thickness, and the refractive corneal scarring. So we normally grade them early, moderate, advanced, and severe. Depending on that, we can plan the surgery. So early cases or moderate cases, you'll hear from Dr. Namrata Sharma. We'll be doing a cross-linking of corneal collagens to strengthen the cornea and decrease the progression. These patients can also be treated with the contact lenses also. Advanced cases would require a surgical intervention. And some cases we can manage with the new generation contact lenses also, where we can avoid surgery in these patients. The corneal transplant surgeries are a last resort in these cases, because even after corneal transplantation, you may require contact lenses rehabilitation in these cases also. Just to summarize, as I said in the beginning, we have a higher prevalence in an Asian country like India and Middle East. It is a multifactorial disease. The basic association of genetics, protein damage happening to the collagen fibers, and structural damage happening in the cornea, which causes thinning and conical shape of the cornea. Physically, eye rubbing and allergies are very common association with keratoconus. And most severe cases will have faster progression. They are younger patients. Younger the patient, more is the progression of disease. And family history is a very important aspect to be checked in these patients. Early diagnosis, treatment is a very, very common. Future-wise, genetic analysis, as I talked about, for early detection. And we are all working on artificial intelligence as the base for early diagnosis and the treatment in these cases. We all know once you develop a keratoconus, so you have to live with this disease. It cannot be reversed totally, or cannot be cured as such. So our idea is to detect as early as possible before the physical damage happens in the cornea, so that we can preserve your good quality of vision and good quality of life. Because once the distortion has occurred, the distortion cannot be made into normal as such. The basic idea is to understand disease and pick up early enough where we can preserve your vision quality. And the last and most important part is the counseling of people, especially with family history in the family and the people who have developed keratoconus as such, and rehabilitate them not only visually, physically, and other socially also in these cases. And surgery, as a last sit-out, we like to avoid as far as possible surgery in these cases, because we have so many treatment modalities which can avoid surgery nowadays in more these cases. Thank you for your kind listening.